Again, good afternoon to everyone. Welcome again to our learning sessions for pharmacology. The learning objectives and outcomes for this afternoon is the discussion of the pharmacokinetics. The second is to identify concepts and differentiate mechanisms in pharmacokinetics on absorption, distribution, metabolism, and elimination. And another learning outcomes or objectives as well is to elaborate situations that are relevant on the pharmacokinetics, specifically on drug administration. Now, we will start with our discussion on pharmacokinetics with a video presentation that has been uploaded also in your MCU BLE. Let's talk about what pharmacokinetics is.
Hi, this tutorial is the first in the Pharmacokinetics series. So first of all, I should talk about what pharmacokinetics is. Within pharmacology, we often talk about two distinct, but unfortunately unintuitively named branches. These are pharmacokinetics and pharmacodynamics. Briefly, pharmacodynamics is the study of the effects of drugs on the body. That is, what does this drug do to the body? What receptors does it activate? And what other effects does it have? Alternatively, pharmacokinetics is the study of the effect the body has on drugs. In pharmacokinetics, we ask questions like, how does the drug get into the body and where does it go? What does the body do to the drug? And how does the body get rid of the drug? It is this branch of pharmacology that we will be looking at in this series. So let's begin with a pharmacokinetics acronym you'll find in every textbook of pharmacology. ADME. A-D-M-E. This stands for absorption, which is how the drug gets into the body. Distribution, which is where the drug goes to in the body. Metabolism, which is how the body chemically modifies the drug. And finally, excretion, which is how the body gets rid of the drug. These are four elements we need to consider when talking about the pharmacokinetics of a certain drug. The following tutorials will each talk about a certain aspect of pharmacokinetics. But for the remainder of this tutorial, we are going to discuss some of the more boring but incredibly important aspects of pharmacokinetics and pharmacology. So I'll begin by drawing a graph. And here on the y-axis, we have the concentration of drug within the body. And on the x-axis, we have time.
Okay, if we talk about concentration of drug within the body, I even told you that once a drug enters the body will identify, specifically through the function of our liver, on what concentration of drug is only appropriate and needed by our body. But once the drug enters our body, it will reach its peak concentration level until the time that the slope of the graph goes down. It means that the 100% or bioavailability of the drug, which is the 100%, will be divided into percentages of the component of the drugs that can be utilized by the body, and the other percentage could be the one that will be excreted by the kidneys, which is not anymore needed by the body. When it comes to the time, later on, it will be discussed why we consider the concentration of the drug and the time. Class, always take into consideration that the drug will reach its 100% concentration if the drug reach the plasma. And when it comes to the time, this will entail on the situations when a drug enters the body and thus the pace of time that it will reach the plasma. Example, can we identify the difference if the drug will be given intravenously and if the drug is administered via oral? What do you think? What do you think is the route of administration that will have a fast pace and will reach immediately the plasma? Is it through intravenous or through oral route? Answer,
IV po.
IV. Why IV? Because obviously intravenous, inside the venous is obviously blood, and the blood has component of plasma. So that's why in this analysis, the if you will analyze that at the concept that I have emphasized, that the drug may reach immediately the peak concentration level with intravenous fluid compared intravenous administration compared to oral route of administration, simply because the drug itself reaches already the plasma. Compared to the oral medication, it will pass through the GIT before it will reach the plasma. Let us continue with the video presentation.
If we give a person a drug at time 0, then we will see the concentration of the drug go up, and then it will fall slowly as the drug is removed from the body. And that's what we see on this graph. So looking at this graph, we can see that in this section, the drug enters the body faster than it is being removed from it. Therefore,
okay, the one that is being identified here from this coverage of 0 up to this time, this is the time that the drug enters the body. Okay, and at the time that it reaches its peak concentration level, it means that the drug already reaches the plasma. And what happens next?
concentration of the drug in the body increases. Then, after the peak of this graph, the drug is being removed from the body faster than it is entering. So the concentration of the drug in the body starts decreasing. This point.
Now, when it comes to the mention the excretion of drug is faster from the time that it enters the body. That is very true, because eventually when the drug comes in, this is now the time that since it reaches the plasma, and the one that will only be carried by the plasma is the appropriate percentage of the quantity of the drug that will be circulated sa body. Why is it said and mentioned that more faster the drug will be out of the body or eliminated? Simply because this is for purposes to prevent that it will reach toxicity level. So the body determines the percentage of the quantity and percentage of the amount of the drug that is needed by the body, and those that are needed must be immediately removed so that to prevent toxicity level. That's why, for instances, that if the drug reaches this point of peak concentration level, and this time the liver and the kidney will now function immediately to remove the excess properties of the drug. If situations like that, the person do have a problem with liver and kidney, so very obviously that it will cause a delay. Very obviously that it will cause deviation in removal of the excess properties, chemical properties of the drug. What may happen if it may not be released out of the body because of situations and limitations that kidneys and liver is damaged? That's the point, that the drug may eventually reach its toxic effect. Once the drug will reach its toxic, actually it may not immediately have toxic effect, but rather it may manifest first with adverse reactions. And with these adverse reactions, if antidotes will not be given, that's the time that we expect a severe adverse reactions that will lead to toxic effect. Let us continue with the video.
This point at the top of the graph is important because it is the highest concentration of drug in the body. Therefore, we call this the maximum concentration, or Cmax.
The Cmax is what we call maximum concentration or peak concentration level. As even emphasized, this is the time that I have mentioned and reiterated that the drug reaches the plasma.
This is important because knowing the maximum concentration can help predict the therapeutic benefit and also the likelihood of side effects. The time at which the maximum concentration occurs is called Tmax. Now, a slightly more confusing concept.
Now, since it involved the time, from the time that the drug enters the body and reaches the peak concentration level, that is the time also that the drug reaches its maximum time. So obviously, as what we have mentioned in our example, we have the intravenous and the oral. So probably if we will expect oral medication, the slope could be like this. It will be farther or it could be longer time as expected, for example, with intravenous, because the longer time that the oral route will have its mechanism is expected with the oral administration compared to the intravenous that will reach immediately the peak concentration level because the drug already reaches the plasma. And thus, it also identifies the maximum time. Let us continue.
Is the half-life of a drug. The half-life is, by definition, the time it takes to remove half of the current concentration of drug from the body.
Now, it mentioned about half-life. I mentioned about that when the drug enters the body and reach its therapeutic effect and reaches the plasma, it's 100%. That's bioavailability. But when the time that the drug reaches the peak concentration level, it means that the 50% of the drug is already taking effect to the body. And the other 50% is definitely will be released out of the body. So that's why with that effect of the drug, it is very important and it is very much rationalized that the drug must be given on the right time and frequency. So if we say half-life, that is 50% effect of the drug, and bioavailability is already the 100%. We say a while ago that when it reached the peak concentration level, we have considered bioavailability, but the whole process itself is the 100% bioavailability. And once it reached in this point, at this point, the 50% of the drug is already absorbed by the body, and the other 50% can be removed out of the body. So that is what we call half-life.
So let's consider the half-life on this graph. If we begin at Tmax, we want to see how much time it takes for the concentration of the drug to decrease from Cmax to half of Cmax. So here is the half Cmax line here. And therefore, the half-life, which is often denoted T half, is the time between Tmax and where I've drawn T half here.
Okay, so we have mentioned a while ago that when the drug enters the body and reaches the peak concentration level, we have the bioavailability. Once it costs the particular half, because this is the 100%, the bioavailability, and the half peak concentration or maximum concentration and the half of the time is considered the summation of half maximum concentration and half time is considered as half-life. When we say the peak concentration level and the maximum time, we are talking about bioavailability. So just simply think that bioavailability, we have 100% and we have for the half-life of 50%.
So just to summarize, the time it has taken for the drug to drop from its maximum level to half of its maximum level is the half-life. On this graph, this is the time between Tmax and where I've drawn T-half. There's a lot more to talk about with half-lives. Including rate laws and orders of reactions. But that is beyond the scope of this video, so we'll talk about that in a later tutorial. The last thing to look at is the area under the curve, and this I have illustrated by shading in the space under the graph. This represents the total exposure to a drug that the body receives. This is a function of how high the concentration of the drug gets, as well as how quickly it's excreted.
So from this area under the curve, as the total exposure of the drug, this is the time that it will give you the idea that that's why drugs are given every 8 hours, every 6 hours, 3 times a day, 2 times a day, because the drug itself already identifies that if, for example, for every 8 hours, the first drug had been administered at 12 noon. So after 8 hours, the next dose will be at around 8, 1, 2, 3, 4, 5, 6, 7, 8 o'clock. So 8 o'clock. So when we talk about the peak concentration level, okay, peak concentration level, from 12 o'clock up to the 8 o'clock, which of what time can identify the half between 12 and 8 o'clock? What is the half of 12 between 12 noon and 8 o'clock? Anyone? What is the time? So if we have 8, so it's 4 o'clock. Okay. So if it's 4 o'clock, the 4 o'clock that we are talking about is that is the time that the drug already reaches its peak concentration level. Okay, peak concentration level, and that's the time that the drug starts to remove out of the body some of its chemical properties that is not useful. Now, if it's 4 o'clock, what is the half between 12 noon up to 4 o'clock? 2 o'clock. Okay, very good. From 2 o'clock, it means that the 2 o'clock is the time wherein we consider the half-life of the drug. So that's why it has an implication if the drug will be given not on time, because it will really affect the half-life and the peak concentration level of the drug. Any questions so far? Any questions so far? Is it clear? Or do I need to explain it further? Students?
Clear po, Team.
Okay, clear. Thank you. So now we will go to the next slide. The next slide is talking about the pharmacokinetics, which mentioned in the presentation of the video. It usually pertains to the movement. We are considering movement from the route of administration until it reach its target organ. And the 4 stages that we have mentioned are ADME. We have the absorption, the distribution, metabolism, and elimination. Let us now start what absorption is. When we talk about absorption, this will pertain on how the drug enters the body through the route of administration until it will reach the systemic circulation. From the time that I have discussed about pharmacokinetics, from the drug that may enter the body until it reach the blood, specifically the plasma, and facilitate the what we call excretion and elimination to remove the properties, the chemical properties of drug that may not be needed by the body. Let us now have the presentation of the video pertaining to absorption.
Tutorial is the second in the pharmacokinetics series. And in this video, we're going to have a look at absorption, or more specifically, routes of drug administration. If you haven't seen the previous tutorial, I highly recommend watching it before continuing with this video, as we will use terminology which was introduced and defined in that tutorial. So I'm going to begin by drawing a very simplified body plan. And this body plan follows the flow of blood from the digestive system to the arterial circulation. So let's see how this happens. So blood flows from the gut to the liver via the hepatic portal system. Blood then flows from the liver back through the venous circulation and into the right side of the heart. The blood then flows through the pulmonary arteries to the lungs. Then from the lungs back to the left side of the heart, then out into the aorta and into the arterial circulation. What we are going to do is place drugs into different parts of this system and measure their concentration in the arterial circulation over a period of time. So I'll draw a set of axes.
Okay. Before the presenter continue his discussion and present to you again a slope. So now when a slope and a graph. Now when we talk about the basic knowledge in anatomy and physiology, the one that has a major contribution when it comes to pharmacology is the circulatory system. So that's why when we talk about absorption, it shows on the video that when a drug enters the body via the oral medication, so obviously it will enter via the GUT. So we have the gastro, it could be urinary tract, gastrointestinal tract. So once the stomach initiates a synthesis of the drug, it will be absorbed via the intestine. And as what I have told you, it will be detoxified by the liver. Class, most of the oral drugs will be detoxified by the liver because eventually it will pass through the GIT. Question, sir. How about those drugs that will be inhaled and direct to the respiratory tract? Next, sir, how about those drugs that can be administered by a topical through skin? Will it still pass the liver? Sir, how about those drugs that will be given direct intravenous? And actually, it will reach already the plasma, sir. The answer is most of the oral, actually all of the oral medication is the one that is only significant, which will pass through the liver for detoxification. And indeed, with this liver, the one that we call, or the term that we call, that the metabolic response when the drug is absorbed by the intestine and the liver detoxify it is first pass effect. The first pass effect is identified for oral medications that will significantly consider the function of the liver to detoxify. And once the drug already detoxify, it will separate those components that is not anymore appropriate for the body and the one that is needed by the body. And once the drug is needed by the body, then it will enter the vein, which we have the what we call the unoxygenated blood, but merely we're talking about in the plasma. When the drug is carried by the plasma, by circulatory system, it will enter to the right side of the heart. As it enters to the right side of the heart, it goes to the lungs. After the lungs, it was converted into oxygenated blood. Still, the drug is carried by the plasma, and this oxygenated blood goes back again to the left side of the heart. And from the left side of the heart, it will be ejected to the largest artery of the body, which is the aorta. Once it will be ejected to the aorta, it will be distributed to the systemic circulation. So this is how the anatomy and physiology is very important in pharmacology. And thus, with this knowledge, it will give us the idea on what is the relationship of peak concentration level and the time when it comes to administration of drug. Whenever you will be assigned in emergency room, you must take into consideration most of the emergency drugs are given intravenously or given via inhalation. To what extent? Because these are the access by which drug can immediately reach the plasma. How can you say that, sir? We can say that if the blood enters the vein, it will already circulate through the heart, the lungs, the heart, and close to the systemic circulation. If the drug had been administered through the lungs via inhalation, then obviously the lungs itself is the one that will have its detoxification by exhalation. So some of the components of the drug that may not be needed by the body that are inhaled will be exhaled. Now, if there are some instances that drugs given by oral may still be detoxified by the liver, there are many major routes of excretion. It's not just only urine. There are considerations also via stool. That's why there are some instances that when you take drugs, some drugs, specifically iron-based drugs, those who are taking ferrous sulfate, it will cause dark-colored stool. And originally, as we have mentioned, we have considered if you have taken multivitamins, it is through the kidney, will be seen that some of its properties are taken away out of the body and it appeared evidently in the urine. For some situations, the liver may detoxify it in its removal out of the body. It could be by skin, by sweat itself. So that's why if the person or if any individual have taken a drug, it may manifest also the way the person's odor may identify. And there are drugs like it. So we will continue with the pharmacokinetics.
And on the y-axis, we have blood concentration of drug. And on the x-axis, we have time. We'll begin with the most common route of drug administration, which is orally. These drugs move through the digestive system and get absorbed by the gut. Then they move through this whole system. That is, the liver, the venous circulation, the heart, the lungs, back to the heart, and then to the arterial circulation. This takes quite some time. So what we see is a slow rise in the blood concentration and then a slow fall. Note that the Cmax is quite low and the Tmax is quite large. We'll now contrast that with intravenous administration. Assume that we give the same dose of the drug intravenously. And for those who have read ahead, this drug does not undergo first-pass metabolism. In intravenous or IV.
So again, as mentioned by the presenter, that once drug is given via intravenous, it will not have the process of first-pass effect. While most of the oral medications will pass through the liver on the process of first-pass effect. It was shown in this graph that it has a lower and slow pacing of the peak concentration level until it reaches to the artery, simply because try to imagine that the drug will be processed from GUT, liver, vein, heart, lungs, heart, and artery. And later on, it will differ that the peak concentration level is much sudden and immediate in intravenous because it will not go back to liver and GI. It will unidirectionally consider the direction heart, lungs, heart, again, left side, and to the artery. Let us continue.
Administration. The drug doesn't have quite such a long journey to reach the arterial circulation, as it only has to go to the heart, the lungs, back to the heart, and then to the arteries. This results in a quicker rise of drug concentration, which might look something like this on the graph. Note that the Cmax is larger and the Tmax is smaller. even though the dose was the same. This is because IV is a more direct route of administration than orally. Now contrast this with inhalation of a drug. Let's again assume that we have given the same dose of the drug as the last two examples, but this time we are giving it as an inhaled form. Many anesthetics are actually given this way. The drug now only has to go to the heart and then straight on to the arterial circulation.
Now, the third example of route of administration is via inhalation. And if you will try to see, and it was mentioned, most of the inhalation route are given with anesthesia. So, from this journey in the physiological response of the body, number one is oral, liver, first pass effect, vein, the heart, lungs, goes back to the heart and artery. If it is given intravenously, then we have the blood from the heart, blood towards the heart, the lungs, the heart, and the artery. But if we talk about the inhalation, it's directly processed by the lungs. Compared with the slope or with the graph that you're seeing, this is the peak concentration level of the oral medication, and this is the peak concentration level compared to the intravenous. Much immediate compared with oral medication. Let us see how inhalation had been processed.
This means we will see the concentration of the drug shoot up very quickly. So note the much larger Cmax and the even smaller Tmax via this route of administration. Also, remember that in all these three examples, the dose of the drug was identical, only the route of administration changed. So you can see how different routes may cause a radically different Cmax and Tmax.
Now, from this comparison of number one, oral, number two, intravenous, and number three, via inhalation, because in number three, which is inhalation, shorter journey, shorter pacing are expected, because the lungs, from the lungs, it just proceed to the left side of the heart and proceed to the systemic circulation. So that's why if you have noticed, the peak concentration level is shorter time compared to intravenous, compared to the oral medication.
This is important when considering the applications for certain drugs. For instance, if you need pain relief quickly, then an IV analgesic will get into the system much quicker than an oral one. Conversely, a drug which has side effects at high concentrations may be toxic if given intravenously, but the same dose might be safe if given orally.
Now, all of these drugs, rather, one drug is being administered to the patient. It's just so happen of different routes of administration. Same doses are being considered from oral, intravenous, and via inhalation. Now, the difference is that there are some drugs that may not be given on any of these routes because of the chances of risk for toxicity level. That's why there are some drugs that may only be given via inhalation. There are only drugs that may be given accordingly via intravenous, and there are only drugs that may be given via oral medication. Let us continue.
Now I have three more points I want to make. Firstly, note that the area under the curve is the same for all these routes of administration. This is because the amount of exposure to the drug, that is, the dose, is the same. Just some routes of administration spread the dose out over a greater length of time. Secondly, you might be wondering why the same drug is excreted at different rates, or more simply, why curve number 3 falls quicker than curve number 1. Without going into too much detail, I have chosen to show a drug that conforms to first-order kinetics. If you don't know what that means, it's okay. We'll cover all this in a later tutorial. But it basically means that the rate of excretion is proportional to the current concentration of the drug. If the concentration of the drug is high, then it will be excreted faster than if the concentration is low.
Okay, so it's clear. The higher the peak concentration level, the faster that it must be removed out of the body. Why? Because the most of the drug that may be given on a higher peak concentration level are the one that has been considered as risk for adverse reactions or toxic effect. So that's why the body must respond immediately. Unlike for oral, it could be processed by the first pass effect through the liver to prevent adverse reactions and toxic effect. Unlike for the lungs and for the intravenous, it may not retroact to the liver to have the first pass effect.
Also, it's important to note that the half-life of the drug is the same regardless of the route of administration. This is because the half-life is a property of the drug, not the route.
Okay, when we talk about the half-life of the drug, let us start with the number 1. If you will notice, this is the graph from the number 1. So basically, the half of this, okay, the half of this graph is considered the half-life. For number 2, the half of this graph pointing here is considered as the half-life. And from the number 3, the half-life of this drug goes here, and thus 1 as the half-time. So the summation of those of the half concentration and the half of the time is half-life. The peak concentration level and the whole process itself of 100% effect of the drug is bioavailability.
It will take the same amount of time for the drug to reach half of the Cmax orally as it will to reach half of the Cmax intravenously. This is because the Cmax is different for each route of administration and the rate of excretion is proportional to the current concentration of the drug. In the next tutorial, we'll look at the metabolism of drugs. In particular, we'll look at the actions of cytochrome P450 in the liver.
Okay. Any question from the audiovisual presentation, class? I'm not hearing anything. Any questions?
None so far po.
None
Thank
po.
you, thank you. So I need the answer so that probably all has been cleared. So now let us proceed. Let us proceed with the absorption. So the movement of the drug wherein you will just remember that the movement of the drug in absorption is AAS. So remember that mnemonic, AAS. It means the A is from the administration site. And what we are talking about with the administration site is either oral, it could be intravenous, it could be intraosseous, direct to the bone marrow. It could be sublingual under the tongue. It could be other routes such as topical through the skin. This is what we call administration site. And once the drug is starting to be absorbed, it will definitely proceed across tissues. It's not yet within tissues. It's still superficial, across tissues, starting or primarily. Once it will reach it will primarily consider across tissues. Then once it reaches the systemic circulation and reaching the plasma, that's the end of the absorption phase. Actually, when it comes to the degree and rate of drug absorption, it may depend or it could be affected on the following. From the video presentations that we have, anatomy and physiology as it is associated concept, we have presented the oral, the intravenous, and the oral, intravenous, and the inhalation. So if you have seen the difference of the 3 route of administration from its peak concentration level and the half-life. So that's why when you want to have immediate pain relief, obviously the pain relief that you may have if you wish to have immediate relief, is obviously via inhalation. But do we have a drug basically prepared for pain for inhalation? The answer is yes, but that is only anesthesia. Second, if for example, you wish to have a pain relief immediately, and since anesthetics could not be appropriate on that pain management, then probably you may consider intravenous. But it may depend actually on your condition. If it is just mild pain, probably oral medication could be sufficient. But expect, when it reaches the peak concentration level and the time that it will have its effect could be different from inhalation, could be different from the intravenous, and definitely different from oral. Can you imagine that once you take a drug, a pain reliever for oral medication or oral route, it will take the possibility of its effect from 15 minutes to a maximum of 90 minutes. And that is equivalent for 1.5 hours before it will have its full effect. So with this understanding, it is very important for all of us to have the basic knowledge when it comes to route of administration. Next, absorption may differ from patient's age and physical condition. When it comes to patient's age, we have the children or the population groups of children, the adult, and we have the aging population. When it comes to the aging population, metabolic response of the body varies. I just want to ask you students, which of the following age group has the slowest metabolic response? Lowest metabolic response. Do we have the pediatric or the child, the adult, or the aged?
Teens yung sa ano po, yung sa mga matatanda na po. Mga elderly.
Yes, elderlies. Kasi if you will notice, the metabolic response of the aging population has the slowest response. So that's why absorption of the drug may be also vary with the age. And we expect, for example, the drug had been given orally orally to a child, to an adult, and to an elderly. Same drug is given but of different dose, because different dose, the dose is dependent on the weight. And on that note, when a drug is given to these population groups of the same drug, when it comes to the effect, the slowest pace of peak concentration level for oral medication in this population group is for the what? The elders. So that's why nurses, we need to take into consideration that you might mention that, I give already to you the medication for your pain. Why you're still in pain? What's the basic knowledge? The basic knowledge is that of the absorption could be dependent on its rate and degree by age, and we expect slowest metabolic response to the elders. So our knowledge itself will keep us more patient in dealing the elders when it comes to drug administration. The physical condition that we're talking about is that of, for example, I have mentioned to all of you that the major organs that are greatly involved in pharmacology is, other than the brain, we have the liver and the kidney. Whenever these conditions are present as comorbidities to clients, then obviously absorption could be affected. Other than the liver and the kidneys, how about if there are problems with blood vessels? Even though it's given intravenously, it may not meet its objective to reach the plasma because of identified problems with blood vessels. So these physical conditions may deviate its objective for absorption. Next, we have lipid or water solubility of the drug. So remember, lipid or water soluble, when it comes to solubility, which is more soluble? Kasi lipid are identified also yung mga oil-based drug. Okay? So which of the two drug, water-soluble drug and lipid-soluble drug, may have fast absorption? Is it the water-soluble? Or correct. Because we all know that lipids or oil are insoluble or may be breakdown on a slower pace compared to water-soluble. That's why when the drug enters the stomach, the lipid-based drug and the water-soluble drug will be break. Okay, will have its breakdown on its chemical components so that it will be absorbed efficiently and effectively. But compared to a water-soluble drug, this is more effective when it comes to time pace because it could be easily absorbed compared to lipid-soluble drugs. Next, potential interaction with other drugs or food. Class, there are some situations later on, drug interactions will be discussed on a later part of our topic. Actually, that's in the pharmacotherapeutics. Class, some of you are having these measures that you are taking drugs with a beverage, with a drink. Example, a drug that you will take with milk. There are some instances that the milk may change the chemical properties of the drug, and that may affect absorption. Another, how about if you take the drug, ito sometimes unconscious, you're very unconscious. For example, if you take ascorbic acid, then you mix it with concentrated orange juice. Do you think it may affect absorption? Yes or no? You're taking ascorbic acid, you take it along with concentrated orange juice. Will it cause interaction? Will it cause a problem ba? Yes or no? Think. Toot, 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 toot. Any insights from our students? So meaning your silence, sir, please answer. Okay. Class. Ascorbic acid. From the drug itself, acid. Second, okay. I will see the ano. Okay. So some of you answered the pH level. Kasi class, if you will search yung pH levels of some of the foods and beverages that you are having, the pH level matters when it comes to the premature breakdown of the drug. So can you imagine acid? Second, you will take it along with the concentrated orange juice, which is also high in vitamin C. And it reaches the stomach, which is the pH expected is acidic because of the presence of hydrochloric acid. Do you think it will have the premature breakdown, the immediate breakdown of the chemical properties, which may affect the supposedly percentage of the chemical components that will be absorbed towards the intestines? Yes or no? Yes or no?
Yes po.
Yes. So that's why there are some instances that it is discouraged for you to take drugs with high concentrated, mga high concentrated, highly acidic beverages, because it will counteract the effect of the drug. Why? It will affect absorption. It will have premature breakdown of its chemical components, and that could not be sufficient for absorption for the intestine, and somehow it will still be detoxified by the liver. So probably there will be a lesser percentage of the chemical components that may not support the need of the body. So on that point, do we consider okay, we have the other preparation. Di ba meron tayong ascorbic acid, meron tayong sodium ascorbate. Plus the sodium the ascorbic acid and the sodium ascorbate. The sodium ascorbate is the one that may not cause hyperacidity. The ascorbic acid is the one that most of the time causes hyperacidity. So that's why when you're taking sodium ascorbate, so the same yun the same yun na ascorbic acid Yung isa lang is generic is sodium ascorbate. That's the one that may not cause the hyperacidity. On that note, pwede naman siyang inumin with orange juice, pero syempre you think of the you think of the pH level of what you are taking then from the drug that you're also taking. If you're taking sodium ascorbate, which is ascorbic acid, and you're taking orange juice, although there are some artificial, I'm saying yung concentrated fruit juices I'm saying yung talagang from orange juice extracted orange juice. That's the more concentrated. Pero kung artificial, ano naman siya, orange drink, na mas mataas pa ang sugar content nun, that may not affect because it's not really identified with the high pH level. Mas mataas ang sugar level when it comes to the artificial food drinks. So, I hope I have answered it. So next po is, when we talk about the stages of drug absorption or drug movement, we are talking about the medication administration routes. I know for a fact that this has been introduced. Am I right? This has been introduced to you? Not yet. Students. The routes of administration? Yes or no?
Na-introduce na po.
Okay. Now I will just ask questions. Now, when it comes to the routes of administration, we have enteral routes and we have the parenteral routes. If we say enteral, enter. You just remember enteral, enter in the gastrointestinal tract. Okay. So most of these routes will involve the gastrointestinal tract. Outside the gastrointestinal tract is referring to parenteral routes. Just like as for enteral, we have oral, buccal, sublingual, and we have rectal. For parenteral routes, we have intravenous, vein. Intra refers inside. Intramuscular, inside the muscle. Subcutaneous, meaning under the cutaneous tissues. Otic is referring to the ear. Conjunctival, the eyes. Nasal, obviously, via inhalation but passes through the nasal cavity kasi may mga drugs that are through the mouth But some drugs must be through the nasal cavity. So that's nasal. Inhalation, so probably this could be in a form of nebulization, this could be form of direct administration, and topical is referring to the administration via skin. Let us have a review of what are enteral routes and parenteral routes. Let us start with oral. What you're seeing on the slide is just a mnemonic for you to remember whenever we're talking about oral routes. When we say 2-CASGIP, okay, 2-CASGIP, it means that 2C, AS, GI, P. Okay. So 2 Cas-Gip. If we say 2 Cas-Gip, the first C is this route is common. The second C is referring that this is the convenient. Letter A is AS, absorption is low, AS. GI, meaning most it causes gastric irritation. And P stands for usually the root for pain medications. So oral is 2 Cas-Gip, 2C, AS, GIP. C, most common, another C, convenient. AS is absorption is low. GI, it experience gastric irritation. And P, usually for pain or typical root for pain medications. Talking about that, most of the oral medications will really experience gastric irritations because obviously the breakdown, the initial breakdown of the drug for absorption is initiated by the stomach via hydrochloric acid. The longer that the drug stays in the stomach for absorption, the chances that it will increase the acid pH in the stomach. So what are the preparations that could be given by oral? It could be tablet, capsule, pills, powders, or liquids. Any question with the oral? So just remember 2 Cas-Gip. Any question? Hearing none, let us proceed to buccal. For buccal, you will just remember C-Gup with H at the end. C-Gup. C-Gup meaning for buccal, the drug is being administered between the cheeks and the gums. So that is the CG. Now, when it comes to the pH, why include the pH? Because it will require optimal strength of pH. The pH that we are referring to via the buccal, di ba we have the saliva there? And the saliva has a certain pH level. And with a certain pH level, it will require optimal strength to possibly absorb through this administration route. So we have oral, 2 Cas-Gip. For buccal, we have C-Gup, which is CG, administered between the cheeks and the gums. pH, it will require high level or optimal strength of pH. The most common drug being given by a buccal is an example, fentanyl. Fentanyl is a drug, usually pain reliever, that are given for cancer pain. So whenever situations or individuals diagnosed with cancer experiences obviously pain, for pain relief, most of the drugs, specifically fentanyl, are given by a buccal. Next, let us now proceed with sublingual. Sublingual, you will just remember TARBs. What TARBs mean? The T is the drug is administered T under the tongue. AR, it absorbs rapidly. So once it will be a focus on a question in the board exam, the one that is considered absorption is low, that's oral, 2 Cas-Gip. Once it talks about absorbs rapidly on enteral route, we have sublingual. Usually, the RB, or rather the ARBS, AR means absorb rapidly. The BS is usually the drug is direct to bloodstream. So that's why TARBs, under the tongue, AR, absorb rapidly, BS, direct to bloodstream. One of the drugs that are very common in and it is given by sublingual is nitroglycerin. Nitroglycerin is indicated for chest pain. And we all know that chest pain is an emergency situation. Chest pain, its sign is an indication that the heart is lacking oxygenation. And if it continues, if the chest pain manifests continuously, it may have a higher degree of worsening condition, to the extent that at first there's only insufficiency of oxygen, but on the later part, when the chest pain exceeded 15 minutes rather, that's an indication that there's already tissue death. And try to imagine the heart. The heart is a halomuscular organ. The muscle itself is the one that keeps the heart pumping. And once there will be tissue death of the muscle or muscle tissue death, do you think the heart will still pump and contract? That may merely affect the contraction of the heart. On that note, nitroglycerin are given, and this is a vasodilator. This will dilate the blood vessel so that to facilitate the continuous flow of the blood, which we all know that the blood carries the oxygen, and the oxygen that will be used by the myocardial cells. So that's why it is given under the tongue, which is sublingual. Next drug, route of administration. Route of administration referring to rectal. Then one of the mnemonics that I have considered it is right. Right. What do you mean by right? The R stands for, obviously, it is inserted in the rectum. AI is obviously it is absorbed in the intestinal tract. And basically most of the drugs that are given via rectal is for those who may have constipation. The one that you have witnessed and watched most in the advertisement, the Bisacodil, Dulcolax, the rectal laxative suppository. So if you will encounter suppositories, these are drugs that are being administered via rectal. And remember, right. It is inserted via rectum. It is absorbed via intestinal tract. Another example of drug that may be given suppository, lalo na pag mga convulsions, febrile convulsions for pediatric clients, and no available site for intravenous is inserted yet. And obviously, oral medications may not be conducive for an infant who's experiencing fever. Paracetamol suppository could be one way to facilitate prevention of febrile convulsion. Now, we have ended up about enteral routes. Let us now have a review of the four. What is the mnemonic for oral? What is our mnemonic for oral? Two, if you can still remember,
Kasgip.
two kasgip. Okay. Anyone, what two kasgip means? C.
Common, convenient,
Okay.
absorption is slow, most cause of gastric irritation and pain medication.
Thank you so much, Ms. Prestosa, for that active participation. You are correct. Let us now proceed with buccal. How about for buccal? What is our mnemonic for buccal?
Sigup.
Sigup. Okay, what sigup means? This is the drug is being administered via letters C and G. Between C and G.
Between the
Cheeks and gums.
Very good. And it may require optimal strength of
pH level.
pH level. Next, how about for sublingual? What is our mnemonic for sublingual? We have
Tarbs.
tarbs. Or what does tarbs means?
Under the
tongue. Very good. Continue.
absorb rapidly
Absorb rapidly. Correct.
directly into the bloodstream.
Bloodstream. Thank you so much. That's correct. Last but not the least for enteral, we have the, ayan, I forgot. We have the, what you call it?
Rait po.
Yan, we have the right, rectal. Okay. So what right means, Miss Mesa?
Insertion of drug into the rectum po.
Correct. And
Absorb,
AIT?
absorbed by the intestinal tract po.
Okay, very good. So I hope you have mastered already those enteral routes. Now, routes. Let us try to discover what's the correct pronunciation. It's routes or route. Kasi we have route of administration and route as in ruta for the ways. Let us discover how it is pronounced correctly. Now, let us proceed with the parenteral routes. For parenteral routes, let's start with intravenous. For intravenous, try to let's consider the mnemonic DOBS. Okay, DOBS. Or what does DOBS means? It's obviously direct to vein. Okay, direct to vein. AB is access to bloodstream. Okay, so DOBS means direct to vein. ABS is access to bloodstream. Okay, or rather, we could do it in this way: DABS, direct access to bloodstream. That could be the same because it's DOBS. Now, the commonly use of this route is for intravenous fluids, and those intravenous fluids in colloquial, you've heard about suero. Those are intravenous fluids, and obviously these intravenous fluids are such preparations for hydration and for other purposes such as drug administration. This could be absorbed and administered directly through the blood vessel and via bloodstream. So obviously we have mentioned that these drugs, if it is intravenous, it will immediately have the higher peak concentration level and peak time because it will reach directly to the bloodstream. Bloodstream plasma rather. Let us now proceed with intramuscular. So we have DOBS. For intramuscular, we have ML, HS, B3. So we'll just remember intramuscular ML, Mobile Legend. Okay, wow. Mobile Legend, HS High School. Okay. ML, HS Batch 3. ML, ML, Mobile Legend High School Batch 3. Okay, ML, HS, B3. Now, what does ML means? I am, obviously, muscle. LH is less hazardous. Okay, less hazardous. Then, the B3 that we're talking about is B stays blood longer, and 3, maximum volume that can be administered via intramuscular is only 3 ml. So we have ML, HS, B3. M, muscle. LH, less hazardous. B, blood longer or longer stays longer in the blood. And 3, maximum of 3 ml can be given. Class, put this in mind. Anything that will be given intramuscularly and it is given 90 degrees right, class, it can only hold 3 ml. If it is more than 3 ml, don't take risk. Why? Chances that if you will administer 3.5 or ml or 5 ml, this may cause damage to muscle tissues. And you will be accountable to it. Why? Because this may not be, this may cause harm to the muscle tissues of this number or this volume or amount. So that's why take into consideration the ML, the HS, the B3, muscle, less hazardous, stays longer in the blood, and 3, maximum of 3 ml administration or holding. So class, it stays longer, kaya that's why there are some instances now when a drug is given intramuscularly, the longer its effect, because it stays longer in the blood. Pero try to imagine kasi the flow of absorption just the same as what we did in the analysis of absorption in the in the oral. Kasi oral, pass through the GUT, pass through the liver, then so on and so forth. While from the muscle, before it will reach the plasma, from the muscle, it will pass through the different layers pa before it reach the intravenous, before it reach the blood vessel and proceed to plasma. Kaya the pace of its effect before it reach its desired effect is longer compared than with the intravenous. So it means yung peak concentration of intramuscular is lower compared to intravenous. So class, another is actually this is very important when in pediatrics kasi there are some instances that you will administer vaccines to pediatrics. Usually for intramuscular, it is not recommended for ventrogluteal or dorsogluteal. Why? Because for ventrogluteal and dorsogluteal, you may possibly hit the sciatic nerve. Okay? You may possibly hit nerve. And once you hit a nerve, this may cause the possibility of paralysis. And that will be your accountability. So as much as possible, not recommended, least actually not na, it already identified not, don't consider the site for intramuscular for ventrogluteal or dorsogluteal. Where is the usual site for intramuscular? Do anyone knows? Where's the usual site for the intramuscular? Even you are given with ano, di ba usually, I know for a fact that most of you have received intramuscular vaccine.
Deltoid po.
Deltoid, thank you. Deltoid, so it has also, deltoid is the common site for the intramuscular, not recommended for the two mentioned sites. So next we have the what we call subcutaneous. For subcutaneous, you will just remember FTSM2. FTSM2. Okay. For FT, full-time. Punta sa SM, 2 o'clock. Okay. Full-time SM2. Oh, may bagong SM sa ano, sa Monumento, Grand Central, ha? SM Grand Central. Pero ha, pag nag-limited face-to-face, no. Baka after office hours, doon ako magbabantay. Okay, let us continue. So we have FTSM2. Subcutaneous, it's obviously the fatty tissues. These are the fatty tissues, SM between the skin and muscle. Okay, FTSM, this is administered on the fatty tissues between skin and muscles, and that's why I indicated 2. For subcutaneous naman administration, the maximum volume of drug that can be given is maximum of 2 ml. Do not exceed 2 ml, but a minimum of 0.5 ml. Minimum of 0.5, maximum of 2 ml. If it is 3 ml, don't take risk. Because again, this may cause tissue damage. Okay, so the same with the muscle. Actually, for the intramuscular, it stays longer in the blood. But for the subcutaneous tissues, there is gradual absorption. So what's the difference in here? It stays longer, but for the subcutaneous, there is gradual absorption. So I forgot to mention pala, before I continue with the subcutaneous, one of the example that are given for intramuscular is haloperidol. Okay, this is different from olol, ha. Haloperidol is an antipsychotic drug. Okay, so this is given intramuscularly. It stays blood longer, so the effect is longer. So that's the principle. So going back again to subcutaneous tissues, for subcutaneous tissues, gradual absorption. Ibig sabihin, the absorption is slow, but it stabilizes. So one of the example is insulin. Insulin is given as, obviously, as these are hormones, but as drug that is given Insulin is given subcutaneously, and class, this may require gradual absorption. Why insulin must be given subcutaneously? Class, if you will give it intravenously, it will cause sudden drop of the blood sugar. And the sudden drop of the blood sugar may not be, okay, may be risky for the person, because instead of stabilizing the blood sugar, it will contribute to hypoglycemia or hypoglycemic shock, too much lowering down of the blood sugar. So that's why, remember that insulin must be administered via subcutaneous. Another is some of drugs such as heparin. Okay, drugs ending in rin, warfarin, heparin, aspirin. Okay, rins. These are anticoagulants. If we say coagulation, di ba class, if there's bleeding, to stop the bleeding, it must coagulate. Okay, now, the point here is anticoagulants are given because there are some situations like, I'll just give you an example. If there are damage that are basically happening in the blood vessel, to prevent continuous bleeding, it will clot. But try to imagine that the clot itself is the one that will cause obstruction to the blood vessel and may interfere circulation. That happens when, if there is damage in the brain, blood vessel, I'm referring to damage in the blood vessel of the brain, it will bleed to the blood vessel, it will cause clot to the blood vessel. Do you think that clot may cause an obstruction to that blood vessel in the brain? Yes. That eventually may lead to stroke. Another, for the heart. If there will be a damage in the artery of the heart, which is the coronary arteries, it will cause bleeding, and eventually it may cause the clotting, because to prevent the bleeding. And the clot itself is the one that may cause the obstruction. And heparin or anticoagulants are given. So it is only given subcutaneously. However, there are some emergency cases that may vary its route of administration depending on the attending physician. Now, I may not focus on this structure, okay, on this structure, but eventually it will just give us the focus on how those drugs happen, or how the drugs are basically summarized in this graph or in this illustration. These are the methods of administrations: the topicals, the oral, the intravenous, and the parenteral. And these are the forms. It could be by inhalation, by the solids, the transdermal. And these are the nursing responsibilities. So we need to take into consideration the rights of medication, which I have already introduced to you, the 5, but later on we'll introduce the other rights of medication. Now, why I keep on emphasizing the relationship between the time to its effect. This is class, try to bear this in mind for you to have the knowledge that drugs must be given in an emergency situation via either intravenous or intraosseous, because the effect of the drug takes place within 30 to 60 seconds. Intraosseous, direct to the bone marrow, 30 to 60 seconds. What is our rationale why it took only 30 seconds to reach its peak concentration level? Because our rationale is that of, when you are considering this route of administration, the drug will immediately have peak concentration level and it reaches immediately the plasma. Endotracheal. When we talk about endotracheal, the tube that are inserted inside via the trachea. Have you seen situations like in the ICUs, or for now in situations those who are intubated? The tube, okay, the tube that are being inserted via the oral and direct internally to the trachea is endotracheal administration because drugs can be given also via endotracheal. So it could be endotracheal, it could be via inhalation. By inhalation, it could be by face mask. So we're talking about anesthesia. Face mask could be by nebulization. So it will take 2 to 3 minutes. Why? Di ba a while ago we have discussed about yung absorption na yung travel na lang ng drug from lungs will take only back to the left side of the heart, then goes back to the systemic goes to the systemic circulation. It just only 3 pathways. Unlike for the intravenous, it goes to the vein, it goes to the right side of the heart, to the lungs, to the left side of the heart, then circulation. But however, even though with that journey, the concern is that of by intravenous, why it's more on the 30 seconds because it's already directed to the plasma itself. And while the endotracheal is, it will still be considered as 2 to 3 minutes by inhalation because it will pass through that phase. Next, sublingual. Sublingual, we have mentioned here that under the tongue, it will take 3 to 5 minutes. So that's why it is expected for a person who are having chest pain and given with the anti-anginal. Okay, angina is the medical term for chest pain. Nitroglycerin is also called as anti-anginal. So those drugs given sublingually, expect this effect 3 to 5 minutes. So with this knowledge, class, it is expected for a nurse to have observation of the client in chest pain that within the 3 to 5 minutes, pain relief must occur. And if it passed through the 5 minutes, another drug will be given again. But once it exceeded 15 minutes, it's a worsening condition. So on this scenario, so a question. So tanong lang po, kung under pa rin po ba ng pharmacology ang radiation therapy or hindi na po? Actually, radiation therapy may not be or may be considered in the pharmacology because it's still used it's still used particular preparations, but the preparations only. But the radiation therapy is another, I think it may not be a major coverage in the pharmacology because it uses direct radiation. However, it includes pharmacology or it involves the concepts of pharmacology prior to the preparation for a patient who may undergo radiation therapy. So hoping I did answer the question. Now, talking about intramuscular and subcutaneous. For intramuscular, the effect takes place from 10 to 20 minutes. Subcutaneous will have 15 minutes to half of an hour, which is 30 minutes. Rectal, 5 minutes up to 30 minutes, and by ingestion. This is what I'm talking about, oral medications. For oral medications, it will take 1.5 hour. So 30 to 90 minutes if it is oral medication. So that's why will you consider oral medications for emergency cases? No, because basically it may lead to complications before it reach its desired effect. Now for transdermal, for the skin, if it is administered via the skin, it may vary via either minutes or hours. So in this situation, there are concepts that had been introduced to you in chemistry and in the microbiology about the absorption. Usually, when we talk about the mechanism of absorption, it could be via diffusion, passive diffusion or carrier-mediated diffusion. What is the common term in this? Is diffusion. If we talk about diffusion, is it referring to absorption from higher to lower concentration or lower concentration to higher concentration? Diffusion. Is it higher to lower concentration or lower to higher concentration?
Lower to higher concentration.
Higher po to lower po.
Ayun. Okay. So thank you for the try, but our answer is referring to higher to lower concentration. Just like from the video presentation that we have. 'Di ba? Di ba we're talking about magre-reach siya ng peak concentration level. Yung pag-reach once it reach the peak concentration level, ibig sabihin higher. concentration. And di ba naglo-lower concentration siya pag pag nasi-separate na yung property of the drug that will be absorbed and that will be removed by the body. So that's why most of the mechanism of absorption is via diffusion. Moreover, when it comes to pinocytosis, okay, to the pinocytosis, the absorption takes place to various compartments of the body. So probably the absorption could be via some of the fluids present in the body. Example, if we are having in the heart, we have pericardial fluid. If we have in the bone, we have particularly with the lungs, we have the pleural fluid. Sa brain, we have cerebrospinal fluid. Sa peritoneum, we have peritoneal fluids. So on this matter, the absorption takes place as carried by this fluid. So various compartments, it could be intracellular or extracellular compartments. Now, when it comes to the next, this is a video presentation that will consider basically from the, we ended up with absorption. Let us now proceed with distribution.
In this tutorial, I'm going to talk about the distribution of drugs within body compartments. In the previous tutorial, I said that this video would be on the metabolism of drugs, but I've decided that it's probably best to talk about the distribution of drugs before we move on to metabolism. For the purposes of distribution, we can consider that the body is made up of 4 major compartments, which are really collections of fluid, and numerous minor compartments. These major compartments are the blood, or strictly speaking, the plasma, fat, extracellular fluid, and intracellular fluid. Then there are numerous other minor compartments. These include the cerebrospinal fluid, the peritoneum, synovial fluid in joints, and the fetus in pregnancy.
Okay. To give emphasis on this, so di ba the absorption ended up with the systemic circulation. So let us go back again to what absorption is. Di ba absorption is AAS, administration site, across tissues, and we have the systemic circulation. So once the drug reaches the plasma, it will start already distribution. And when it comes to distribution, how the drugs will be distributed accordingly. This is the plasma, and we have various compartments where the drug can be distributed. The cells are divided into intracellular compartment and the extracellular compartment. So that's why we have the intracellular fluid and the extracellular fluid. Thus, when we talk about other compartments, there are fats rather, with the tissues that may have fats. The other fluids that we consider is the cerebrospinal fluid, obviously in the brain, the peritoneum, the peritoneal fluid, the synovial fluid could be through the joints, and the fetus is obviously with the amniotic fluid. Now, on the mechanism of distribution, if you have seen the arrow of go through and back, simply because the drug could be in any of these compartments based from what is its indication. So on that matter, class, remember, since the cells is divided into intracellular and extracellular compartment, remember class, we have electrolytes. For extracellular compartment, we have the what we call highest positively charged electrolyte for extracellular is sodium. The highest negatively charged electrolyte for extracellular compartment is chloride. That's why, di ba, I have mentioned in the intravenous fluid, it is given direct to the blood and reach directly to the plasma. And the first that will reach the cell itself is the extracellular fluid, extracellular compartment. And with that, most of the intravenous fluid preparation are composed of sodium and chloride. Kaya that's why when we are talking about dehydration, the one that is being emptied sa cell ay ang extracellular compartment. That's why most of the intravenous fluid has sodium and chloride. Now, on the intracellular compartment, the highest positively charged electrolyte is potassium. Okay. And the other one is phosphate. Now, if already the fluid or the potassium comes out of the intracellular, that is the point that the patient or individual could be high risk na of dehydration. So take into consideration the three important electrolytes: sodium, chloride, and potassium. Sodium positively charged in the extracellular, chloride negatively charged in the extracellular, and potassium is the positively charged in the intracellular, and the phosphate is the negatively charged electrolyte. So in this matter, we will continue.
There are numerous others, but for the purposes of this tutorial, we'll consider these as one single compartment. So if a drug is placed into one of the compartments, we can see how it might move and distribute into other compartments. Often drugs are placed into the blood. These are drugs which are given intravenously. So when a drug is placed into a compartment, it often associates with binding molecules. These binding molecules are often proteins such as albumin. This process sequesters the drug within the compartment, effectively increasing that compartment's storage capacity. And there is an equilibrium maintained between the bound drug and the unbound drug. The unbound drug within a compartment is then able to move into a new compartment, and thus an equilibrium is maintained between adjacent compartments. When a drug moves into a new compartment, some of that drug is sequestered by binding molecules within that new compartment.
So as what I had mentioned, when the drug enters to the plasma, the blood plasma, we have the protein binding components that will secure the drug's chemical properties to be distributed effectively. And the first one that enters is in the extracellular compartment.
This process continues until there is a balance between each compartment and a balance between the amount of free drug versus bound drug within each compartment. The balance between each compartment is determined by a number of factors, and this is best represented using an equilibrium constant. If you've ever done much chemistry, then you'll have definitely seen equilibrium constants before. But if you haven't, then all you need to know is that they are a number which shows whether the balance is in the forward direction or in the back direction. I'm not going to discuss equilibrium constants further here, but I am going to talk about the factors that affect whether drugs would prefer to move into one compartment versus another. Thus, I can say that the equilibrium constant is dependent on the permeability of barriers between compartments, the pH within the compartment, the binding capacity within the compartment.
Okay, I will simply explain this. Yeah, you may not focus na on the KC1, KC2, but moreover, we have these are equilibrium constant. If we say equilibrium constant, this is the one that basically balances on the proper distribution of the drug in these compartments. Ngayon, if we are talking about yung equilibrium and to have effective distribution, we take into consideration yung permeability. Pag sinabi na, if we say permeability, this is the situation on how these compartments are active when it comes to receiving and distributing the components of the drug. If ever, when it comes to the permeability of barriers, example, if the blood vessels are inflamed, if the blood vessels are inflamed, then obviously this could be a barrier that may not possibly, promote the distribution of the blood. If we talk about the pH of compartments, for example, too much acidity and too much alkalinity of the compartment may also have the counteract. It may counteract the drugs for its distribution. Yung too much acidic and too much alkalinity itself. Now, when it comes to the binding capacity, the one that we're talking about with the binding capacity is the protein, di ba? Dun sa protein binding capacity po nito is the proteins, we all know for a fact that once this is in the digestive system, is converted into amino acid, this is very helpful when it comes to tissues. So that's why it also maintains the balance for distribution. On this matter, the binding capacity itself, once there are insufficient protein binding that will help to distribute the drugs itself, it may affect distribution to its indicated organ or system. So probably I may end up to this because it's already 6:57. So we will prepare for your quiz, for your final request, because I have actually set it up at 7 o'clock. So probably we may have first a break. I may adjust the time, or you want to start already at 7. Any suggestion from the group? Because I do understand, because my apology that I have not considered a break this time.